So I understand that I'm the fourth speaker before you get to have lunch, so thank you for that. But it's actually wonderful for me because I get to follow Enola and Greg and Larry, who I think have been able to give you a very nice grounding in the breadth of the field, and it frees me to be able to try and push further. So a lot of what I'm going to say is hopefully engaging you to think with me about some challenges, some assumptions that we often make that we carry through too long potentially, and some ways that we might be able to more thoughtfully think about this broader sense of how do we take evidence and best integrate it within care to the benefit of the people that we're trying to help. Actually, the disclosure that you'll have printed out, I just realized, is a more up-to-date version than this one. The key disclosures are that I stand here as an employee of the National Institute of Mental Health, where my goal is really thinking about nationally how do we provide better research, how do we identify better knowledge that's ultimately going to benefit the entire population of people who are struggling with mental disorders. The key challenge, in addition to the broader services research, is thinking about the knowledge base around dissemination and implementation research. The other bit that you don't see here but you'll see printed out is that I was grateful for being brought here by the foundation. So they did cover my travel. So those are my disclosures. But potentially maybe more important disclosures beyond that are the three reasons why I am here. So the first one is that I've noticed that across medicine, across health, that there's been an increased interest and enthusiasm for really trying to bring implementation science to try and help the overall impact of that field. And so when Leslie had called, and I saw this as yet another opportunity to engage with a group of people who are already thinking in these directions, and how can we work together to build the broader field. The second reason that I'm here is that I have a 6-year-old who absolutely loves Legos. And so when it occurred to me, when I looked a little bit further into where this meeting was going to be held, and I found that Carlsbad, California is not only home to this beautiful resort, but is also home to Legoland, it became necessary for me to make sure that I could try and work it out with my schedule. The third reason, which potentially is more important for me, but at least gives you an insight into where I am when I'm not sitting in the rooms, the buildings of NIH, is that I have a 4-year-old daughter who has communication difficulties. The major issue that she has are motor challenges and motor planning, as well as motor, actual strength, core strength. And so we have been engaged over the last couple years in this search for the best possible communication system for her. And what we found is that at the county level of a very good school system, there's a communications team that has to serve a huge number of kids, has a budget of $60,000. And as we've been looking, and I'll be wanting to pick all of your relevant expertise on this, as we've been looking at different communication systems, the computer-based systems cost something like $18,000 to $20,000 per system. So if you're thinking about a county that's trying to provide these services, and at least these different systems make it very difficult to potentially apply the evidence base, you're in the challenge that we're dealing with. And as we turn our attention to sustainability, we ideally want an intervention that's going to be able to grow with her, that's able to adapt, that's able to provide where she is cognitively. And it's a wonderful little girl who's having a lot of difficulty figuring out, how do I communicate to the world what's going on inside? It shouldn't all just be, can I answer yes, no questions? It's how do I get my preferences across? So the three reasons bring me here today and make me very excited about spending the rest of the time at this meeting with you. Okay, so now on to the fun. So first I want to start with what do we mean? What do, at least when I think about sustainability, what are some of the thoughts that come across? What are some of the definitions that come across? Some of the historical assumptions that have maybe unfortunately gone along with those thoughts. Some research advances. I think that this is an area that's rapidly growing and expanding, needs more insight, needs your thinking about this. And what are those implications for research? So I'm going to try and take you on a little bit of path, and you can feel free to jump up and say, I'm not ready to go down that road, but hopefully you'll be willing to at least cover some of the terrain with me. So when we think about defining sustainability, I go to Merriam-Webster. There's a lot of different definitions. Some of them, I think, embody what is often thought of as sustainability in this space more than others. I think there's a lot of focus on how do we keep up, how do we prolong something being delivered. How do we make sure that it bears up under whatever stress to the system might interfere? How does it support sort of what is going on as true, as legal, as just? The idea that something is sustained over time means it stays equally valid as it was before. This idea that it's confirming, it's enabling us to once again reify that the evidence base that we had developed previously still holds. There's also this cousin you've heard, I think, already about, and you'll probably hear more about, the re-aim model, where the M is maintenance. And when we think about maintain, again, Merriam-Webster defines it as keeping it in an existing state. So I think what Larry did a very nice job of was right from the get-go, talking about these challenges between how do we deal with something as it was originally designed versus the likely adaptations. That whole fidelity adaptation challenge is at the center of our thinking about sustainability. But the challenge is if we define it in a particular way, it may limit our ability to actually arrive at what we might see as an optimal solution. Because if we fix certain parts, we may interfere with the long-term success. And that's where I'm starting from. So the historical assumptions that I think carry from some of these ways of thinking about sustainability are that interventions are developed, the evidence is gathered, and then they're basically frozen. We're trying to say, don't mess with that. We've already established it as true. That fidelity to the intervention is often assumed to be optimal. You have a fidelity scale, and the higher up on that scale, we're at least assuming that that's going to mean that people are getting better outcomes. That we see context, this was mentioned before, as a threat to fidelity and introducing that noise. And who wants noise, right? You want that pristine silence, not a bunch of really happy 6-year-olds running around screaming all the time. That's my own noise. And that sustainability is often seen as the enemy of change, right? We're trying to keep something as it was designed as much as possible. Also, this interesting thing where we sort of pick a particular time point, maybe arbitrary, where it's gone from having been implemented to all of a sudden, we're in that sustainability phase. We're there, it's frozen, we've already passed that, and we're sort of good to go. Now, when we think about some of our sustainability research questions that come up, in some cases, they don't necessarily work so well if we take on all of those assumptions. So if we start to ask what constitutes sustainability of an intervention, we may have to struggle with what is good enough if one is assuming that fidelity is how you define sustainability. Is it also provider adherence to a particular protocol? Is it the competence with which you're delivering an intervention? We have to challenge ourselves to think about time frame and really ask that question of when is something considered sustainable. We need to think about sustainability at different levels of analysis. So sustainability for the patient continuing to receive an intervention as it was designed, the provider continuing to deliver it, the clinic or the broader system continuing to offer it. And then we think a lot about, within implementation, of this question of how far can we get towards sustainability if we're simply extending implementation outward? Do we need specific approaches that are basically focusing on sustainability as the primary aim, not just thinking about implementation down the road? These are challenges that we all have. These are challenges that we want the field to continue to advise us on. There have been signs of progress, and Enola, I think, has been chiefly responsible for a number of them. There was a wonderful conference that she and others had organized, supported by ARC, and you'll see the foundation and WashU, the Brown School of Social Work, where Enola resides. That was basically a couple of days of getting thought leaders together to say, how much do we know in this space? We all know that sometimes it's that footnote on the end of, here's what happened when the research ended. But how do we make that much more a topic of research? The conference products, which I think are hopefully available in different ways, or will be shortly, was that there was a goal of really trying to advance specific research questions around sustainability, that we wanted to think about priorities for methodological advances. What are the opportunities where the existing measures and methods don't do us justice? And then recommendations, which we have been trying to filter in around research funding, which we sit on, but also training, policy, and practice. So there were a number of conference themes which I think represent where we are as a field, at least to some degree the horizon. Advancing the definition and conceptualization beyond a particular dictionary definition to deal with all the nuances and the challenges of the field. Thinking about sustainability really being valued in different ways by different stakeholder groups, many of which were represented for those couple of days. Thinking about how interventions features, how an intervention is designed is going to ultimately affect whether it's sustained. And can we inform better intervention design to that end? Thinking a lot about what theories are available or should be created that specifically explain and ideally are going to help us predict sustainability. And then thinking a little bit more in a expanded way about contextual factors at different levels of the system that are going to impact sustainability. There were some particular research questions, and I would submit that these research questions have not fully been answered. They're things that we would love to see, at least from the NIH standpoint, people investigating a little bit more. So what is the value of sustainability? How can we articulate, not only in terms of reach, but potential ongoing health benefits, maybe not just for the individual, but for populations, for generations, et cetera. Thinking a lot about how different interventions may vary in sustainability, again, depending on how they're designed or how they're implemented. A lot more about this sort of byplay between sustainability, fidelity, triplay, I guess, throw in adaptation. What are the factors that are triggering adaptation? Different things within the system that might make it harder to sustain something in a particular route. Again, can we have, you heard about a couple of times, the review that we did around implementation of different frameworks and models, the 109 that became 61 that became hopefully a helpful resource, didn't specifically focus on sustainability, and so where can we get there on that? And then much more research, observational as was called for, as well as prospective studies, to try and identify how contextual factors affect sustainability. We've also had a number of people who I think have been expanding the terrain of what we think about as far as sustainability. Marianne Shire and Jim Deering have been two of the key ones who've really said it's not enough to just say that something in its original form will likely be able to be sustained forever, that adaptation to some degree is essential to sustainability, that really the organizational assessment or the context and the fit of that intervention is going to be key. That some folks have talked about how they see this very important process of trying to look at long-term success of an intervention occurring somewhere between that initial implementation and that broader sustainability phase. The idea that outcomes assessment, Greg had mentioned this, the feedback can potentially help inform sustainability, or even, as was discussed before, whether things have maybe outlived their usefulness. And then they also argue that capacity building is necessary for success. The memo-driven or the publication-driven solution is probably not going to do so well. So I think at this point in time, today, I would say we have a lot of reason for optimism. There are more and more opportunities to look at sustainability where we've had people who have very systematically tried to understand that initial implementation phase and can now do, in the same way that prevention trialists had done, that follow-up of the population to see how did that original intervention ultimately lead to better outcomes down the road? Same thing here, where that initial implementation effort might enable us to look down the road at what's going on. That they're developing measures, the stages of implementation completion, the sustainability planning tool, which also at WashU, Doug Luke has been pulling together, that may be a pragmatic tool for folks to use to look at planning for sustainability. We have improved ability through technology advances to track more data over time. And I think we've seen, like Marianne and Jim and others, these emerging commentaries and theories that are specifically related to sustainability, rather than, as I said, that sort of last little paragraph that's either hopeful, saying we think this will work down the road, or when we left, it looked like things were still going well. We're excited to see that there's more beyond that. We have a number of ongoing studies. These are just a few that are NIMH supported, but that are specifically focusing on that latter stage beyond just that initial implementation. Greg had mentioned the multidimensional treatment foster care study that Patty Chamberlain's been involved in. Lisa Saldana, who's been working with her, is the one who created and is now testing broader the stages of implementation completion that gets you all the way through this longer-term sustainability. Joan Cook and Greg are both doing follow-ups to their initial implementation study, where they're now looking at sustained use of evidence-based practices. Joan is looking at it for PTSD within VA, and Greg, of course, has been looking at it in terms of foster care, the safe care intervention down the road in Oklahoma and in California. So here's where I want to depart a little bit, and this is where I hope to see at least more thinking, whether it's arguments or some agreement. Ideally, it's more explicit rather than continuing this, that sounds right and let's never talk about it again. So this is really several of us thinking, what do we do if we try and not hold anything constant? If we try and make sure that actual change is at the center of things? So this starts from evidence from the D&I field, where we know that service systems, the contexts are always changing. We know whether we like it or not, whether we acknowledge it or not, evidence-based practices are being adapted all the time in many different ways. We know intuitively, although sometimes it gets lost in designs, that consumers, patients, providers, systems vary dramatically. We know that evidence-based practices are rarely a one-size-fits-all, that implementation is a process, not a light switch where before it was dark and then there was implementation. And we also know that in not all cases does fidelity equal an optimal outcome, and that there's variation in terms of that. And because there's variation, we need to think, at least some of us believe, we need to think, as Larry had said, a little bit differently about this potential paradox, but try and find some happy medium down the road where we're trying to drive toward optimal care. So here are a couple of assumptions that at least some of us think are getting in the way. So here's one. The idea that when an intervention is developed, ideally out of some sort of evidence and packaged, as long as it's beneficial or seems to be beneficial even statistically, it kind of looks the same as you move through efficacy and effectiveness and implementation. Another thing that is often assumed is that it kind of looks the same whether you're at site 1, 2, 3, 4, 100, 1,000. That it's designed in a certain way, and that's what we mean by the intervention, and that's the way it should always look. We ask the question as to whether that's in the best interest ultimately of the field. It is true that in that top line, that as you move from efficacy and effectiveness and implementation, where you identify that there may be something seriously wrong, there are, of course, efforts to try and say, how might we adapt that to a slightly different set of circumstances? But I would say that too often, once something is manualized, as long as there's that statistical, ideally clinical significance that seems to beat some comparator, we're somewhat happy to say, let's keep it going. It's evidence-based. Even if in our own field of mental health, some of the evidence-based interventions, they do a good job of beating that treatment as usual, but they in and of themselves may only have a sort of 40% benefit. 40% of the people who get this intervention may benefit from it and 60% may not, but because it might beat an alternative, it's sort of good to go. This is actually true in more cases than we would like to admit. So does anyone know voltage drop? Is that a term that folks are familiar with? Okay, some, but maybe not. So voltage drop, I think, is another assumption that gets taken on, reified, and in some case gets in the way of where we want to go. The idea is this, that we fully expect that as we started our efficacy trial, we move on to our effectiveness trial, and ultimately get into implementation. We fully expect that the effect, the benefit of our intervention is going to go down. And there are many, many very well-specified reasons why that's the case. There's heterogeneity and all sorts of things. There are people who have other comorbidities. There's a whole range of folks who look a little bit different, as was said before, than the people who are in our efficacy trial. But in some way, by saying that this is true, we limit ourselves to think that if we don't do as well, that's sort of written in stone. We're not going to get better. So that's okay. As long as, again, it beats some comparator, as long as we're making an incremental advance, that's fine. Does anyone know program drift? Is that another one that folks, okay, so a few more folks have thought about that. The idea, at least as I interpret it, is this also this expectation that as we field an intervention within a context, we kind of assume that over time, as people start to drift away from the manual, the benefit is going to go down. There's a couple things in here that I think are worth noting. One of which is I think that we assume that our best shot is sort of on day one when folks are trained, they're motivated, they're ready to go. So that over time, we're both going to potentially decrease in our effect, but we're probably not open to the idea that we might be able to do better than we did on that first day. Again, the question that we ask is this ultimately going to serve our purposes, which are toward the benefit of population health, toward individual care, and trying to identify how do we align need with necessary tools and resources. In our research, we have this intervention. It takes place within a context. I would argue that most of our studies weigh intervention and context in the following manner. We think about our intervention as being so incredibly important and really the focal point. And that context is something that actually does get in the way. And how do we enable ourselves to ideally understand it, but even better to, in some way, we think, control it so that it doesn't interfere with the delivery of our intervention? I think this has actually been done over and over again. We would argue that if you're looking at interventions in contexts where they're being delivered, the natural process that you see is actually that adaptation is inevitable. And little by little, your intervention is being changed to look like something that fits better within the context, not that pristine intervention manual that you started out with. And that as the sooner that we can embrace this as a natural process, it may enable us over time to develop better lessons, better information from the field that hopefully can better identify that fit between intervention as context. The other thing that we think about with our evidence within an intervention, within a context, is that things are always evolving. We should expect that we're learning more and more about the evidence base. We should certainly expect, as has been identified, that adaptation changing of the intervention is always occurring, and shouldn't it be? I mean, unless we truly feel that from the beginning we got it right. That would be amazing. But the iPhone begat the iPhone 2, the 3, the 4, the 5, the 5S, the 5C. Things change over time because of a belief that maybe things can get better. And certainly, even though a lot of our studies do the contextual assessment on the front end, some of them are now looking at context over time. We know context is changing, and we lose a lot if we hold on to that assumption that once we've mapped out the context in any setting, that we're good to go forever. That nothing like, say, a big national healthcare reform financing kind of thing is going to get in the way, or other sorts of changes. You know, far be it that there are other ways, maybe better ways of delivering care over time. We want to see that more and more these changes that we fully expect to happen if we think intuitively are reflected in our thinking about how best to study them. Whether there's changes in the evidence base, the environment, the practice, people, you know, we know turnover, Greg has studied this a lot, about how challenging it is, of course, when people get trained and then the turnover rate maybe, you know, they're only going to be in that job for 8-9 months or even less than that, right? We talked a lot with mental health commissioners, state commissioners of mental health, finding that the average lifespan of a commissioner in that job was 18 months. And that reflected those who had been there for 15, 20 years, along with those who got in and said, hey, we're here, we're ready to get things done. Oh, there's another job. So we know that all of these changes are going on, but we rarely think about them as core elements of our study. And we want to. So it's on multiple levels, and there's multiple domains with which we're trying to ideally account for and even sort of listen to and adapt to change as it's existing. So what we had pulled together, this is a couple of colleagues, you can't now at the bottom see the type, but it's myself and Russ Glasgow and Kurt Stange, had tried to think about, is there a way in which we can reflect what we see as this dynamic process? It's by no means perfect. If it was perfect, well, it will never be perfect, but if it was a little bit more accurate, what you would see is this three-dimensional orb of things colliding and changing shape and all of that. The best that we could try and do is say, look at the puzzle piece, which is that intervention. Over time, we're fully expecting that it's going to change, and ideally, it's changing in a way that makes it to better fit with the context, which also, by the change of the shape slightly, is changing at every time. We saw the ideal for actually planning for and trying to respond to this change using, you know, borrowing from the quality improvement literature. That's where you see the Plan, Do, Study, Act. That's a shorthand for whatever process you can systematically go through to look at that fit between the intervention and the context over time. Ideally, ways not just to say, how do we move the context around to keep our intervention the way it always looked, but ways in which we can learn to ultimately try and improve the overall benefit. You'll see this overarching circle is our way of trying to say that we truly believe that if you're sensitive to this fit over time, and it's done thoughtfully in terms of gathering this additional evidence at these different levels, ideally you should be able to do much, much better than you ever did from the beginning, where you were really just trying to see how might this work in this new setting, having not been there before. And so we do see this as an evolving space, but ideally it's a way to try and incorporate this notion of ongoing learning, of ongoing improvement, and not just at the organizational level, but subjecting our interventions to the same kind of questions that we often reserve for our context, I guess, or reserve for the noise that we're trying our best to clear out. So I do think that there's a number of areas ripe for exploration across all of medicine, certainly in your area as well. I think that we can look much more at sustainability of evidence-based practices as they're being delivered, as big changes in the healthcare context are occurring. That we can now look a lot more at adaptability and even evolution of evidence-based practices over time, if we assume that adaptation is not necessarily bad. That I think we have increasing opportunities to think about scaling up practices where they're being delivered across health plans, across systems, across networks. Hendricks Brown and his center was referenced before, but adaptive designs, one of the things that we've been thinking about methodologically, are can you think about implementation as this sort of stepwise approach where new challenges are occurring, new questions that might lend themselves to different options. So it might be very nicely contributing through adaptive designs in this space. Real-time feedback and monitoring as another way that we think we could learn a lot more. And very importantly, studying what we call, it's either de-implementation or ex-novation, but this notion of maybe we should also be focusing on those practices that may even be evidence-based, may not be evidence-based, but are clearly not good fits for the service systems and the practitioners and the client population that's trying to deliver them. So I think we do have, within this notion of dynamism, we have some key components that we should be further along month and month as we go along than we were before. We have outcomes management systems and the technology in place to be able to look in less and less invasive ways at our clients, our patients, our consumers, however we term the people we're trying to reach, getting better. We certainly have more and more scope, as some of the investigators in this room have already shown, in looking at quality measurement over time. Is the intervention being delivered in a high quality way? We have more and more opportunity and really good resources to think about monitoring the adaptation. How is the delivery of the intervention changing within settings, across settings? And we have more and more opportunity with data sets to look at how organizations are changing over time. Our argument is if we look at these various sources of data, ideally we'll have a much better understanding of that particular fit between the intervention and context that we see as so incredibly important. So the take-home messages from this, we had the recent meeting, which I think there will be more resources on as it comes. We now do have assessment tools that are able to bridge into sustainability that I think are going to be helpful. I will say that I think our traditional view of sustainability, starting from that notion of to keep preserved in that original state, may be limited, but this is a tremendous opportunity for further research. We need to understand more about the time frame. We really need to think a lot more thoughtfully about this notion of fidelity versus adaptation, and as I have heard Kurt Stange and several of us have talked about, evolution of interventions over time. We all, or many of us, believe in evolution in other domains. So why shouldn't we believe that our interventions can evolve as well, and ideally natural selection, the better ones are maintained, and that we think that this ultimately will optimize the effect of the intervention. You'll see a few references that are suggested, and please contribute more, because this really is an area where there are relatively few empirical studies. There are some growing, as I said, commentaries and theoretical pieces, but there's great, great scope for helping us all to think about this.